Welcome to More Than Miles, the podcast where we use storytelling and expert interviews to widen the lens on what it means to be a happy and healthy endurance athlete. We believe that athletes are so much more than their body, sport, and training miles. I'm Dr. Kate Mihevik-Edwards.
And I'm Dr. Kacy Sinders. We are endurance athletes, physical therapists, and huge coffee addicts. We spend most of our time treating, educating, and working with endurance athletes. Thank you so much for tuning in today. Now let's get to the show. Welcome to More Than Miles. Today we are talking about upper or proximal hamstring injuries, both from an overuse and traumatic perspective. So we're literally talking about a pain in the butt again. I feel like we have talked about other issues with this region, but today we're really going to focus on the high hamstring. It's a topic that's near and dear to my heart. I'm sure I'll tell my story of how I tore mine in high school and my subsequent bitterness about it.
Let's jump into this topic. And we picked this topic of high hamstring or hamstring injury because it's a common thing that we see in the clinic. And we actually see a ton of high hamstring because this is an injury that can present in many different ways, but often isn't very quick to resolve. So we want to kind of go through the anatomy, some differential diagnosis and symptoms that you might have, and then how to get going and get this better. So the first things first, the hamstring is made up of three muscles. It's the biceps femoris. And please tell me what that's like in your British accent.
It's the biceps femoris.
I just had to because it's one of her favorite muscles to say.
Thank you for teeing that up for me, Kate. I appreciate it.
You're very welcome. And the biceps femoris has a long head and a short head. And then we have the semimembranosus and the semitendinosus. They all attach to the ischial tuberosity, which is basically that sit bone or that butt bone that you feel when you're sitting in a chair. And then they go all the way down and they attach to the proximal tibia and fibula. So proximal means top of. And they're innervated. So the nerves that kind of run through those muscles or in charge of those muscles are the common peroneal nerve, the tibial nerve. And then there are L4 through S3 run through there as well. So that's kind of the basic anatomy and understanding of kind of where it is. And of course, it's on the back of the leg. I didn't say that, but if for anybody that doesn't know, sometimes people get the quadriceps and the hamstrings confused, and that can be easy to do, but it's the back of the hamstring attaching at the butt down to the back of the knee. And the hamstring, its job is to create stability in the lower extremity or the leg. It helps with stability on one leg, and it helps with internal rotation of the hip, extension of the hip, and knee flexion. It also helps with overcoming that braking force during running. So when you first hit the ground, the hamstring helps with that. So a lot of times runners have a hard time with the hamstring because of that action during running.
Yeah, a very powerful contraction. And I think that's kind of the crux of why a lot of people develop these issues. And so if you do have pain in this location, right, so we're talking right along the sit bone or right where the hamstring kind of feeds into the glute. I hear some people will call it in the clinic. We want to make sure that we are treating the correct tissue and that we are getting the right diagnosis, because there's actually several different structures that could cause pain in this particular location. So the biggest sneaky one is the obturator internus.
Did you say sneaky?
I did say sneaky.
This is my favorite. Obturator is.
Yes. So this was actually the case study. So when Kate hired me, obturator was one of the differential diagnosis. I think it was actually the answer of the case study. It was the obturator and not the proximal. So if anyone's trying to get a job at Precision, I just gave you the answer.
I'm going to change the case study. So there.
Okay, good. So the obturator is again, very sneaky little muscle. And I'm not going to try to describe its location on a podcast because I'm going to use my hands and no one's going to really understand what I'm talking about. But it's a stabilizer muscle of the femur into the acetabulum, so right where that joint comes together. And it also feeds into the pelvic floor. So this is why a lot of people aren't really aware of it and can be a big surprise when they come in thinking they have a high hamstring tendinosis, and I tell them that it's a completely different muscle. Another thing that can cause this is some neural tension. So either the tibial nerve or common peroneal nerve, because we know our sciatic nerve passes right through that sort of right behind the ischial tuberosity and feeds through all the muscles and the piriformis that are located in that region. And so sometimes we can get a very specific neural tension or neural entrapment through the buttock region. I'm sorry I said that so strangely, but we can get some very specific neural tension through that area that can mimic this high hamstring type of symptom.
That's another one that is sometimes missed, is the neural tension. So obturator and neural tension are very, very common issues in runners. And in that kind of location of the hamstring, and they're often diagnosed with hamstring issues when it's really, neural tension related to their back or obturator. So of all the things you've said, I think those are really common ones that are missed and what we see a lot in our clinic.
Going along with that is from the lumbar spine, right? So that L4 to S3 kind of passes through and innervate the hamstrings. And so if we're having any kind of lumbar dysfunction, that can present in this location as well. The most scary thing, or I guess this isn't the most scary thing, but ruling out stress fracture can sometimes be important here too. It's not quite as common to be in like that deep ischial area for the stress fracture to present, but there are some proximal femoral head fractures and pelvic fractures that can present in this area. And we can even get some referred pain from sacral stress fractures as well. So something we want to definitely rule out if we have any suspicion of that.
In terms of stress fractures, the other thing that comes up a lot is if you treat the area and it gets better and the patient goes back home and then a week later it's exactly the same, or the next visit it's exactly the same and you've done that twice or something, you really want to go back and rule out a stress fracture, because a lot of times what happens is that it may look like something else, but if the symptoms never go away and the same exact thing comes back each time, then stress fracture is really something you have to think about, because it's very common for that pattern to occur.
Mm-hmm. Yeah, absolutely. And of course, looking with history, like medical history as well, can help kind of nudge us in that direction as well. And we can talk a little bit more about that later. So also glute referral. So there's sort of some lower fibers of glute max that oftentimes can get angry. I see this quite often and can cause kind of that sit bone area pain. Glute med and glute min have some overlapping referral pain patterns there as well. So that would be an instance where we would treat the glute and we would see some improvement or resolution the next time we see them, because that is a driver of the problem. Of course, among other things, because you have to figure out why are they getting these trigger points in their glutes, so on and so forth. But that is a big thing that I see as well. All right, Kate, you want to talk about symptoms? I can elaborate with my personal experiences.
Sure. So symptoms can be all over the place with this, which is why sometimes it's more tricky than it needs to be. It depends on if it's an acute injury, so something that we have an actual tear, or if it's something else that's more chronic or gradual. So if it's an acute issue, what will happen is you'll be running and you'll have a very sharp pain, and it could be in the butt or the back of the leg. A lot of times it's in the butt. And then you'll get immediate bruising. You might feel a lump in the back of your leg or like a divot. So it might feel that because that's where the muscle tore, and you might have some swelling. So those are the most common symptoms to have when you have an acute tear. And that usually happens when you haven't warmed up very well and you're out maybe doing sprint work or track workouts, that type of thing. And then this will happen. So it's really unfortunate when it does happen, but that's how it kind of goes. I actually had a patient a long time ago who had this huge divot in the back of their leg, and he never really knew what was wrong. And he'd seen several people, which this is usually an easy thing to pick up, but we ended up figuring out that he had a tear of the hamstring during a water skiing trip, and then it just never showed up until later. So that was really interesting. But anyway, other symptoms that you can have are gradual onset. Gradual onset is very common, especially if it's driven by some weakness that you might have, or some tightness or neural tension or pelvic instability. All of those things will make the onset more gradual. You might have pain that's occurring when you're running up a hill or down a hill. You might have a difficult time like lengthening your stride, and you might start to compensate by getting a shorter stride. So your stride will just shorten up and you won't be able to extend that hip as well. You might have an early heel off, or your heel might come up a little bit early. You might have pain in the butt, as Kacy said. That's pretty common. You'll have pain with hamstring activation, like kicking off a shoe. You might also have pain with sitting or putting pressure on that ischial tuberosity. Although I will say that if you have pain with sitting in that ischial tuberosity, it's very common that there's an obturator component. If it's not just hamstring, there's definitely some obturator component if you have it right there.
Yeah. So I think now would be a nice time for me to talk about my experience with high hamstring issues. And luckily, knock on wood, this has been pretty good for me into my adult running career. But when I was in high school, I'm really going to show how stupid I was. So everyone bear with me and just know that my experiences have enriched my ability to be a good healthcare practitioner because I've done all of the things that a lot of my patients do. So I was 16. I remember because I just started driving when this happened and I couldn't drive. But I was 16, sophomore in high school, and had been, running and being my extremely dedicated self for track and field. And I did the 800 and up. And I had started to have this kind of dull sort of tightness and pain in my left hamstring and left upper hamstring. At the time, I didn't really know what it was. And of course, like any runner, I just kept running. And, it got to the point to where I did have that sort of asymmetrical stride. I felt like I couldn't really extend that leg out very well. And again, like any good runner, I just kept running, thinking that it would just go away, right? Now that I'm telling this, I think my coaches really should have stopped me, but they did not. But anyway, long story short, we had the first track meet of the season. And because I'd missed all of my freshman year, because yes, you guessed it, another injury or different injury, I was like, I'm not missing this track meet. So it was my only open 800 that I've ever raced. Probably scarred for life after that, but also I don't have the speed for it. But anyway, I went through the first 400, limping along or whatever my stride looked like. I was keeping up with the pack of girls, but it was pretty ugly. And then the second, so in track, you're taught to really pick it up the last 150. Went to put in that little bit extra power, and I felt a pop in my hamstring, right up at my glute, and, fell down on the track and walked it home. Right. So anyway, fast forward, when I went to get this checked out by a medical practitioner, we took an x-ray, and the x-ray showed, again, I was 16 at the time, my growth plates had not fused yet. But it showed that my growth plate had gotten tugged off of my ischial tuberosity by the few hamstring fibers that kind of got tugged and pulled there in that race. That took a long time to resolve, but yeah, a lot of pain with sitting, sitting in class was miserable. It took probably 3 or 4 weeks to go away, or 3 or 4 months to go away. Did not address it properly with PT. Really wishing I would have. But luckily things have worked out okay here, going forward. But anyway, it was not a fun injury, and it's definitely something that should be addressed properly, especially with it being the close in proximity, to the pelvis and all of the other muscles that cross that area. If you've got a really true weakness there, it can really cause some issues both up and down the chain. So.
That's right. And I think some of the parts of your story that you really touched upon were some great learning points. One is most of us PTs have been injured at some point in another, and that's why we are in the field that we're in. And so we've definitely become better, more empathetic healthcare providers because we've been there and we know how much it sucks, to be honest. The other piece is, your coaches probably should have stopped you, and there needs to be more education around these types of issues with teams early on in high school, middle school, and then obviously collegiate runners and forward. And I think that oftentimes we push our runners as hard as they'll push themselves, which we know most runners will push themselves and beat themselves to the ground. So we need to be better at supporting our athletes. And of course, that's one of my soapboxes. I'm very sorry, but I had to say it.
Yes. And the other thing I kind of touched upon is this idea of an avulsion fracture, which actually can happen in multiple different parts of the body. This is where a tear of a tendon actually pulls off a portion of the bone. And again, this can happen in multiple different locations of the body, but that's what that would have been considered. Even though it was the growth plate, it still is considered a partial avulsion fracture.
Right. And that usually happens with younger kids. So kids that you said you were 16, so high school athletes, that type of thing. It doesn't typically happen in middle-aged adults. Like ourselves.
Like ourselves, yes.
But if we're talking about risk factors, we should go through some of the risk factors for hamstring injuries. And definitely one of them is age and not warming up and overuse, pushing yourself harder and harder. All of those things were in your story. But older runners are actually at risk for hamstring injuries, more of the overuse and kind of in the tendinopathies category or tendinitis category. If you're older than 40, definitely in that category. I think a lot of postpartum runners are at risk for this because of the changes in their pelvis. So if we have this pelvis that kind of tilts more anteriorly, and it may or may not come back postpartum, right? So postpartum is forever. If that pelvis doesn't get back into more of a neutral position, then they're putting that tension on the hamstring for a longer period of time. Anytime you add speed work to your program or you suddenly increase your speed within a run, those are risk factors. Again, I don't want you to be worried that this is going to happen if you pick up your pace. That's nothing. It's not true. You don't need to necessarily worry about that. But if you haven't been warming up or you've noticed a lot of tightness in the hamstring or you notice any weakness, then you might consider this. So you have to be doing a good warm up. A nice dynamic warm up would be really helpful to avoid this. And, strength. We always talk about strength and mobility, and that is something that every runner should be doing. I think at this day and age, we're aware of that, and a lot more people are talking about it. When I was first running, nobody did strength training. We barely even did mobility. So now, hopefully, we all know how important both of those things are.
I want to elaborate on the anterior pelvic tilt piece of this a little bit too, because it's not only postpartum runners. This could be really anyone with any sort of anterior hip tension, which is a lot of us from sitting and so on and so forth. But if you guys can imagine this, right? So if our pelvis is tilted forward, we're lengthening the location of that proximal hamstring tendon. So our hamstring is always on some sort of load. And the less we're able to control that pelvic tilt, the more that hamstring will take on load with that braking force. And once we get into treatment and things like this, we will talk a lot about posture, lumbopelvic posture, because being able to control the pelvis and the tilt of the pelvis is going to be really key to not only get this tissue to recover and offload a little bit, but also to prevent it in the future.
That was a really great explanation, Kacy.
Thank you, Kate.
You're welcome.
I learned from the best.
It's like you're in my head, but better. Why don't you talk a little bit about some of the gait changes? We've touched upon a few of them, but why don't you talk about what we see in gait analysis when we see someone who might be at risk for a hamstring injury, but also someone who might have a hamstring injury?
Yes. So this is a big key of our treatment. We talk about gait analysis all the time on the podcast, but I really like the way you phrased this, because I will do gait analysis in the clinic all the time, and I'll be going through everything. The patient will be like, well, is it a chicken or the egg situation? Am I running like this because I have pain, or is this what caused it? And the answer is both. And regardless of if it's a chicken or the egg, this is a really bad analogy, we want both the chicken and the egg to be healthy. So you can't keep running like that if you want to be healthy. So regardless, we need to fix it. I know you liked that one.
Oh, God.
So what might we see, right? So shortened stride, either asymmetrically or symmetrically, just trying to avoid stretching that area, avoid stretching the hamstring. This is exactly what I looked like hobbling around when I was 16. Because of this, the running gait might be louder. So if you have your patient on the treadmill, or if you are running on the treadmill or even outside, you might hear a little bit of a difference between one footfall versus the other, with that injured side being a little bit louder because you can't control that braking force and you want to get off of it quickly. I think this goes more under the risk category, but we might see limited hip extension. And so this is not only a mobility issue, but it can be a glute activation issue. And it's meaning that when you get that foot on the ground and that leg is kind of traveling behind you, and when you get to that push off phase of gait, you're using a lot more of that hamstring, particularly the upper fibers versus the glute. And so again, once we get into treatment, we'll explain kind of how do we address that in the clinic. Along with limited hip extension, we might see early heel rise. So this is related to ankle dorsiflexion, but it also can be kind of tied in together with this limited hip extension. Because if you're not able to extend through either of those joints, you're just gonna have to bring that leg forward somehow. And so this is what it will look like sort of in real time and in real speed. Again, we'll see an abnormal posture. So a lot of times anterior pelvic tilt, or we'll see a lot of compensation through the lumbar spine. So a lot of extension or use of the low back muscles to try to compensate for some of that weakness of the posterior chain. And, sometimes along with that sort of excessive curve of the lumbar spine, we'll also see some flaring of the rib cage, or sort of that kind of full body extension, or like running in the back seat, essentially. So, or sitting down on the job. I really like the way you put this, right? So we see these runners, and I do it too. Actually, this is probably why I developed this issue in high school. Anytime I look at my own running gait, I'm always working on that forward lean, and trying to keep that momentum going forward. In my brain, it makes no sense why my body does that. But if we really go into the science of this, right, that's where I'm more comfortable. I feel more stable there. That's sort of what I fall back on once I get tired. And we'll actually see a lot of professional runners do this because they're running at the highest level and they are like fully exerting themselves when we're watching them run. And so they're trying to get forward in any way possible. And for a lot of them, they're going to feel more comfortable leaning back. I think both Sarah Hall and Emma Coburn make me nervous in how much they extend through their lower back when they get tired. But anyway, so those are the things we'll look for and that we'll want to treat. So some of these things are running cues, like running form cues that we can do. But a lot of it is strength and getting that motor pattern in more of an ideal sequence so that we're not overloading that proximal hamstring.
Yeah. And then another thing, Kacy, that we might see is we don't always talk about the arms, but a lot of time the opposite arm. So say your left leg had something going on in the hamstring, your right arm might actually be working a lot harder, trying to help you pull that hamstring through or that leg through when it's not feeling symmetrical. One of the comments patients often make when they have something going on in the hamstring is they say that they feel like one leg doesn't feel like the other. They can't describe it. They don't even know that it's asymmetric necessarily, but they say it just doesn't feel like my leg is gliding through. I can't really figure out how to make it move better and with less difficulty. And so that's a very common thing. So along with that kind of rib cage flare and that lumbar extension, you'll notice that the arms are doing a lot of work and even up in the head. So when we look at running gait, we look all the way up to the chin and the neck and the top of the head. And you'll see like kind of that chin coming up, almost like they're trying to use their entire body, including their head and their arms to move that leg through. And it's a very interesting look, but it often does happen. And I think that the postural piece is one of the most important pieces that you touched upon and that we see in so many athletes. And again, you don't necessarily like to mess with somebody's gait if they're doing well, but you also like to look at it and say, okay, what are the things that could come up in the future? And let's prevent that, or let's help to prevent that by maybe looking at changing some posture, maybe in a downtime of a season or something like that. Yeah. So we should probably jump into treatment because we kind of already are talking about it in terms of run gait analysis. So I'll continue with the run gait component before we move on to other things. But a lot of the drills we do are based on posture. So learning how to stack the rib cage over the pelvis, learning how to breathe correctly. You all knew breathing was going to come in at some point. but learning how to breathe so that that rib cage can move and you can have good thoracic mobility and a nice arm swing, being able to make sure that that pelvis is controlled as well. So we might have to do a lot of neuromuscular work or strength work around controlling your pelvis and your breath at the same time, and then adding that to posture, and then adding that to functional exercise and running. So we start with the very basic component of breathing or thoracic mobility maybe, and then kind of layer it on all the way to that run gait component. Other running drills we might do are, sometimes we do leg swings, but it depends, because leg swings are great for mobility, but if you're getting that swing from the lumbar spine and you're not actually getting it from the hip, then that can be a problem. So we have to make sure that the person that's doing the leg swings getting it from where we want them to get it from. We do a lot of rolling patterns to help activate that posterior chain, or so posterior chain, remember, is the back of the body, and that is from the head all the way down to the foot. So a lot of rolling patterns on prone or on your tummy, where we're really trying to get that hip extension, that glute activation, and then up into the back so that we're not using a lot of momentum. If you could see me now, I'm like doing all of the exercises and activities while I'm talking about them. Such a PT.
We'll have to put the video in the show notes or something.
I don't think that's a good idea today.
I want everyone to see you in your sunglasses.
I mean, we could just do a cool picture, but I don't know. My old lady. Good thing they're Gooder, because at least Gooder are cool.
Shout out to Gooder. You want to sponsor us? Let us know.
Oh yeah, that'd be great. You know what I was thinking about today? A little off topic. I was walking the dogs, and earlier I had the dogs in here before we were recording, and they were just too loud, so I left them out. But I thought, if we actually made money on the podcast and we're sponsored, we really couldn't have our dogs around, because we'd have to make sure that we were really, really professional.
Yeah, we would both have issues with that. I think mine whined a few minutes ago, so I'm sorry if you guys heard that, but he's up on the bed and sleeping now. It's his gotcha day. I've had him a year.
Oh, that's really awesome. Congratulations.
Yeah. Thank you.
We always digress to the dogs, don't we?
It's the content people want to hear. So.
Oh, I'm sure. Okay, so back to posterior chain work. So we do that with some rolling patterns, but also there's many ways to do it. I mean, you might start to do just hamstring curls on the ball, but even before you do hamstring curls on the ball for the eccentric component, you might just get up, have your feet on the ball, and be able to balance with almost like a backwards plank, right? Reverse plank is really the way you call it, so that you can start to get that stability and pelvic control and breath work all going at once. And then once you're strong and stable there, you might start adding eccentric or lengthening work of the hamstring. So there's a lot of different ways that we can address what happens in gait, but then also what we see in your functional deficits, so the functional testing. But then we also do a lot of manual therapy, and that includes dry needling. We do blood flow restriction for this type of injury, lots of hands-on neuromobility. The list goes on and on if you want to kind of add some, Kacy, but that's basically what we're doing in our clinics.
Sure. Yeah. So we have to work on the posterior chain strength and the postural control and lumbopelvic posture control component of this. But in terms of actually, if this is a true hamstring tendinosis or tendinitis issue, we really need to remodel that tendon. So a lot of you guys might be familiar with this in Achilles problems. We talked about this in our Achilles podcast as well, where the real key to that tendon remodeling is eccentric loading. So that lengthening sort of contraction that Kate was talking about just a moment ago. And so there's a lot of different ways we can sort of go about this. There's a lot of different exercises, and, certain ones might be better for certain patients versus others. So I don't really want to give any true specifics there, but finding a way to load that hamstring and get it to strengthen and lengthen properly is going to be sort of the key to full resolution here, and hopefully prevention as well. And because of the tendon dysfunction or tendon injury component of this, blood flow restriction training is great because it really allows us to load that hamstring without overloading it, because the blood pressure cuff simulates high intensity exercise without the intensity. we can get all of that good healing and remodeling molecules and substance into the muscle without really overtaxing it through load and weight. So that is a really great thing. I've had some really good success with my patients with that. I've had a handful of proximal hamstring injuries that have responded really well to that. The other thing, going back to the breathing, because I know that I want to make Kate proud. So another reason why that's important, right, is because it's really key to using your core and glutes correctly. So if you're able to regulate the pressure within the abdomen, you can actually maintain your pelvic posture and you can use your glutes. Because if you're not able to be stable in that posture that we're working on, you're still going to use the muscles that we don't want you to use, such as the hamstrings and so on and so forth. It can go on and on. So the importance of pressure regulation, I think, is something that a lot of other medical providers might miss. So we still have to do that. We have to do the eccentric loading. I think that's like pretty high on our list, but also really that lumbopelvic control is key. And I know we've said this several times, but I really want to hit it home because it is the most important part of treatment for these types of injuries.
Yeah. And then that goes back to also, if you have a hamstring injury, I mean, we definitely need to be treating the back if there's issues going on in the back. You can't treat anything in the hip or the thigh without actually addressing the whole pelvic girdle and the lumbar and thoracic spine. I just don't think you can, because you can't really treat the whole lumbopelvic region or that stability without addressing it. So we definitely do a lot of manual therapy, but also stability in the area.
Mm-hmm. Mm-hmm. And, there are other medical interventions. Some people may have heard of PRP or platelet-rich plasma. This is something that's been on my radar since I injured my hamstring in high school. And I feel like I've been quote unquote expert about this ever since, because I read so much about it. This was like, we'd had a computer for a while, but like I finally had the computer like in my room and I could just do endless Google and eBay searches and things. So this is something I looked up a long time ago. And so once I got into PT school, we started talking about PRP. I was like, I know all about that. But anyway, it can be helpful. There is some decent research for it, but I would definitely urge people to find a really good physical therapist and really go through all of and exhaust your more conservative interventions before going that route. Not only because it's expensive, but even if you do get PRP, you still need to have the PT and the changing of muscular patterns and all of this on board as well. So it is an option, but I think physical therapy and functional movement retraining is going to be a must no matter what.
Yeah, because PRP, all it does is go to the tendon itself and work on the healing properties. So it's all about healing the area, right? And that's great. But if you don't address why the area was injured in the first place, it's just going to happen again. So you really are wasting your money and your time with PRP if you don't do the work that's going to help it. And I think most physicians, at least that we work with and that we know, always prescribe physical therapy with PRP, which is awesome. And I appreciate it very much because they know that it's more successful that way. And then there's some stuff coming out with blood flow restriction and PRP too. I believe some new research and some studies are going to be going on about PRP and blood flow restriction. And if you do PRP and then do blood flow restriction within the first, I think it's the first day that they get PRP. I'm not really sure. You can correct me if you're wrong, that it actually is more beneficial. So that's another reason. If you have a provider that does BFR and you are getting PRP, talk with your physician and see if you can set something up with your provider that does BFR same day so that you can get the best benefit from it.
Yeah, that's great. Thanks for bringing that up.
Yeah, no, it's awesome research.
Mm-hmm. Yeah.
Well, and then like we always like to say, prevention is definitely best. And so if you can get to a point where you never actually have a hamstring injury, that would be the best case scenario. So if you're noticing any of the things that we said, if you notice that your hamstrings are getting tight periodically or are tight all of the time, it might be worth looking into. Do you have increased neural tension? Do you need more strength? Do you need more mobility? Why are those hamstrings always tight? maybe you just need a yoga class. Like it could be an easy thing, right? It doesn't have to be difficult. It doesn't even have to involve physical therapy. But if you have some of those things going on, or if you're noticing in your gait that you're hearing one foot more than the other, or you really can't extend, or your back is hurting when you're running, then maybe you should have your gait looked at and work on your lumbopelvic stability and your hip extension so you don't end up hurting yourself. I mean, the other thing is if you're not warming up, you should be warming up, especially if you know you're going to be going faster, or you're going to do speed work, or if you're going to do a tempo run, something like that. Maybe make sure that you're adding that kind of dynamic warm up to help increase blood flow and neuromuscular upregulation so that you can be in the best place when you start your run. So there are a lot of different ways that you can really get into a good spot and avoid this before it happens, if you just stop and kind of think about it and take the time. And time is always the issue. I know that. We all have lives, families, work, whatever, but you're really not going to be happy if you hurt yourself. You'll probably wish you had taken the 5 extra minutes a day that you could do now.
Yeah. And, stretching is not always the answer. So if you have some tightness, it's definitely worth looking into the strength components and the neural tension components. And any physical therapist can help you kind of wade through all of that information. And, it doesn't have to be bad to get better, right?
That's right.
So never too early to address some of these things.
That's right. Well, I hope this episode is helpful if you're somebody that has been struggling with some kind of hamstring injury, or if you're someone who's just interested in not getting one. So we love to do these intermittently throughout our podcast, just highlight an area of the body that we see a lot and that we see injured in runners a lot. So thank you for listening.
Thanks, guys.
Thank you so much for joining us today. We hope that it resonated with you and that you learned something. If you enjoyed this podcast, please rate and leave us a review wherever you get your podcasts. It really helps increase our visibility within the platform so that more awesome people like you can find us.
If you'd like to support us further, pretty please, you can visit our Patreon page at patreon.com/morethanmiles. That's www.patreon.com/morethanmiles. Or for a few dollars, you can help the show grow and keep going, as well as receive exclusive perks like monthly Q&As with us. Until next time, remember to run the mile you're in, and that training is so much more than miles.